You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 12th, 2018. Today, I'm going to talk about exercise as medicine, the concept of ischemia-driven testing, MRI and cardiac devices. I'm going to give a cheer for a pharma company, and we'll talk about screening ECGs but in adults. First topic is exercise as medicine. Now, due to our progress in medicine, more and more people are living long enough to develop heart failure with preserved ejection fraction. I call it the stiff heart problem. You see it all the time in the hospital, especially in older patients. Now, we also know that exercise has proven health benefits, and one benefit in particular is improvement in diastolic function, especially in adults in middle age. For instance, masters athletes have been shown to have improved indices of cardiac compliance. But what about regular people, regular patients? Can they achieve gains in LV compliance with exercise like these athletes? This was the question asked by researchers at the University of Texas. In the largest prospective randomized controlled trial yet, they have indeed shown that a supervised structured exercise, including one high-intensity session per week, in a group of healthy but sedentary adults resulted in, get this, improved VO2 max, improved left ventricular compliance, reduced left ventricular stiffness, improved diastolic function, greater stroke volume for any given filling pressure. Importantly, compliance with this 2-year exercise program was quite good. This was an elegant experiment. The control group here was assigned to flexibility and balance training, yoga training. The most obvious clinical implications are that high-intensity exercise is likely an effective strategy to reduce or reverse the effects of aging on the heart. This study also suggests the need for future studies to look at specific populations at risk for developing heart failure. Think of those patients like hypertension and diabetes, and perhaps structured exercise could prevent many more of these stiff heart kinds of problems that we see. The next topic deals with a tiered strategy for imaging for coronary artery disease. Now, the problem is management of the patient with chest pain and the probability of having coronary artery disease. A group of Dutch researchers publishing in JACC Imaging sought to assess the effectiveness, efficiency, and safety of a tiered CT imaging protocol versus functional stress testing. They studied about 268 patients over 3 years, and their primary endpoint was a negative invasive angiography rate. One group got a calcium scan, and if that scan was positive, then it went to a CCTA, or coronary angiography. Then if the CTA is positive, a nuclear stress test was ordered to assess the degree of ischemia in that stenosis. The other group got exercise ECG primarily. Now, the tiered strategy resulted in fewer cath procedures without significant disease, and a higher proportion of invasive angiograms that had revascularization procedures. The adverse event rates were low and similar in both groups. Remember, these are low-risk patients. The radiation dose was much higher for the tiered imaging group. The authors concluded that this strategy offers a fast and efficient alternative to functional testing. But a nice editorial is pushed back, and for various reasons. I'd recommend reading that editorial. It's worth a look. I have numerous problems with this study, and one is that diagnostic tests, especially ones that expose people to the risk of radiation and further downstream testing, should be shown to improve outcomes, not just surrogate endpoints like, quote, diagnostic efficiency, end quote. Another point here is that about a third more patients in the CTA group received revascularization procedures. That likely represents overuse since there were no differences in outcomes. Another problem is that if the goal here is diagnostic yield, why does one compare the tiered CTA strategy to stress echo? And the stress echo has a much higher sensitivity and specificity, but no radiation exposure. But my biggest problem here is all of this imaging and testing underlies an ischemia-driven strategy. And I think this is a core challenge in cardiology. For instance, in stable patients who have ischemic patients, the COURAGE trial found no benefit in outcomes for PCI. And now recently, the ORBITA trial cast doubt on angina relief. Now, COURAGE included patients with moderate to severe ischemia on nuclear studies. It included patients with multivessel coronary disease. The exclusion criteria in COURAGE were only patients with persistent class 4 angina that wasn't relieved on medicines, a markedly positive stress test, which meant substantial ST segment depression or hypotensive response during stage 1 of the Bruce protocol, or refractory heart failure or cardiogenic shock and an ejection fraction of less than 30%. All other patients with coronary disease pretty much were included in COURAGE. So my question, therefore, is why do we expose low-risk people to radiation and anatomic imaging at all if they have a normal EF and can walk more than 3 minutes on a treadmill? I mean, the best treatment of coronary artery disease is with optimal medical therapy and lifestyle therapies. Yes, you have to exclude a high-risk situation like left main or multivessel disease with LV dysfunction, but after that I ask, what evidence do we have that all this diagnostic testing changes outcomes? Now, please, if you have studies to show benefit of further diagnostic testing beyond basic risk stratification with history, exam, perhaps a basic stress test, or even an echo, put them in the comments section. I'm willing to learn. Third topic today is MRI safety in patients with cardiac devices. Whenever I am asked about whether or not a person with a device can have an MRI, I pause and gather my strength and try not to get unnerved. There are two answers to this question. I say one is the real one, the scientific one, and then the other one is the logistic reality. So yet another study, this one published in New England Journal of Medicine, strongly supports the notion, the scientific notion, that nearly any patient can undergo an MRI scan. The latest paper, a lead author, Dr. Salman Nazarian, and co-workers reported on MRI scans in more than 1,500 patients who had non-conditional devices. Now pause on that for a minute. Every single device in this series is considered on paper to be non-conditional. Now this included ICDs and pacers, and importantly, scans were done with an institutional safety protocol. About 9% of these patients were pacer dependent, and get this, 12% of MRIs were done of the thorax, so they're scanning right over the defibrillator or pacemaker. And the results were clear. It was safe to do this. There were no long-term adverse effects. Only 9 or 0.4% of patients even had a reset to a backup mode, and that meant no sequelae. So yes, MRI scans can be overused. Maybe we order too many MRIs. Not everyone needs the scan. But the point is that when it is the best imaging test, this evidence adds to the already published evidence that MRI scans can be done safely. And the fact that places like my hospital and many other medical centers prohibit scanning patients with non-conditional devices is ludicrous. It's not consistent with the evidence. And I hope I live long enough, practice long enough to see this silly policy get reversed. I'm not sure it will. There are few better examples of how hard it is to undo medical dogma than this MRI and cardiac device story. Next topic is a shout out for pharma. Now, I'm often critical of industry, and I've even been lumped in with the pharma scolds. But a news item this week made me happy for the makers of Rivaroxaban, Bayer and Johnson & Johnson. A Pennsylvania state court judge overturned a $27.8 million jury award to an Indiana couple who accused Bayer and Johnson & Johnson of failing to warn of internal bleeding risks of their drug. Lawsuits against makers of anticoagulants on the grounds of bleeding risk should be shut down. It's just not right to say makers of anticoagulants do not warn against bleeding risk. Of course they do. These sorts of lawsuits are frivolous and distracting, and it makes me angry when patients fear taking a potentially beneficial drug. Now, this doesn't mean I want to strong-arm people into taking a drug, but nothing destroys decision quality more than fear. Now, if drug companies do something dishonest, that's fine, sue them. but you cannot make an anticoagulant without increasing the risk of bleeding. Finally, the last topic today is about screening ECGs. Now, I love the ECG. I do one on almost all patients. I actually think you can get a lot of information from the ECG pattern. But more and more, I see harm from ECG misinterpretation, mostly due to over-exuberant testing and then the unnecessary procedures from this excess testing. That's why the new draft recommendations from the U.S. Preventative Services Task Force interested me. This group of neutral scientists neither endorsed nor rejected the use of ECG screening for AFib, but they did find adults at low risk for heart attack or stroke should not be screened with an ECG. On the matter of screening ECGs in asymptomatic adults, I completely concur. Think about it. After you do a history, patient has no symptoms and good exercise tolerance. Then you do a set of vitals, which shows a normal, regular pulse. There is very little to be gained from doing an ECG. On the matter of screening for atrial fibrillation, journalist Patrice Wendling nicely outlined the ongoing studies looking into this. The promise, of course, is that finding asymptomatic atrial fib will allow treatment to protect against stroke. But the problem is that screening doesn't come without the possibility of harm from downstream testing, nor do we know whether subclinical AFib will respond to oral anticoagulation in the same way that clinical AFib does. Now, the other reason I highlight these draft recommendations is that the USPSTF considers and balances both the harms and benefits of tests. Too often in clinical practice, doctors see mostly the benefits. We forget that any test or treatment has the potential to do harm. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.